Okay, what's going on everyone? Welcome back to my channel. In this video I'll be going through a how to smash your final year OSCEs PowerPoints. Now this is something that I've been doing for a while now. Over like the past few months I've had the pleasure of helping a lot of my friends with their OSCEs. If any of you guys have watched my previous videos, you'd see that last year I had to resit my final year OSCEs, and that was a really big turning point for me in terms of how I approach OSCEs, even just how I approach life and exams in general. It really let me like to lock more into God, especially as my source, and also when it comes to OSCEs and exams, just how to better prep myself. And I really believe like OSCEs, they're just like any other exam. It's not real life. During my time last year, I also had the pleasure of going to get practice and advice from a lot of senior registrars and doctors that also examine OSCEs, especially at the university that I was in. But of course, this one isn't really meant just for my university. I'm sure that it can be applied to whatever university that you're in. I know final years, a lot of you guys have your exams coming up. I know maybe a few of you have finished already. I think Kiel and King's. Well done to you guys. But for any of you that are in a lot of the other like London unis or just the ones that are surrounding, you'll be having your exams now in like the lead up. Hopefully you've already been doing a lot of practice and preparation, and OSCEs with like your friends, and you're trying to engage on placements with your mini kexes and your CBDs and things like that. But hopefully this video should just be a nice run through. Took a while to make this PowerPoint, so just let me know if this isn't really making too much sense, but let's make it full screen and then let's get into it. So why do OSCEs feel hard, and how can you flip it? So there's often a difference between what you feel and what's actually and what actually happens. So some things like I know the medicine but I run out of time, I blank when the actor pushes back, I miss easy marks. Every uni does their stations differently. What you should move it to, OSCEs are performance exams, so it's acting, it's not real life. You won't have 10 minutes to take a history when you start F1. Maybe in some strict ED departments if that's the job that you're working in, but for the most part you'll have time and have a whole year to get faster, to eventually be able to take 10-50 minute clerk-ins if you're working ED in like F2 for example. But you don't need to be that fast. In real life, you'll have all the time to ask your questions, all the questions you want, all the social history you want. There'll be more, like the time will definitely be there. OSCEs, you just have to give them what they ask for. Whatever is on your brief, that is how you should approach answering those questions. I'll go into this more later. So most fails are process failures, they are knowledge failures. So when you fail an OSCE exam, it doesn't mean that you're a bad doctor or that you've chosen the wrong job, and you'll always fail OSCEs or you'll be a bad doctor in like practice. Some people are just better at acting than others, and that's just how it is. But what you can do is just get better at acting, get better at playing the game. Something that I really changed for my reset was being a lot more happier, smiling, being a lot more active, even just coming across as being more confident. I feel is probably the biggest thing that you can do in order to like really change how you feel, change how you move, and change how the examiners see you, because oftentimes they stop listening halfway through. So if it sounds like you're roughly saying the right thing, or if the actor isn't saying anything outlandish back to you, let's say like you ask some like crazy question and they act really stunned, it's things like that that will then make the examiner to start to pay attention and be like, okay, what's actually happening. But really they focus on the start, so your intro, opening question, all the good stuff. Then they focus on the end where you're going through like, let's say like your differentials, or like you're summarizing back, or you're giving like your S-bar for example. So for you to win in OSCEs, you need to have consistent structure, plus patient safety, plus clear reasoning. So structure. Again, I'll go into this more as we talk, but I really feel like this was one of the key things that really helps me with like my resets, because I knew what I wanted to do. I'd always take a quick history, whether it's a station that demands a quick history or a longer history. I'd always do that. I'd also make sure to let the patient speak. At least that first question, what brings you in here? Just let them speak, let them talk, be open, be attentive, listen to what they're saying, and when you're explaining back, do it slowly, avoid jargon, and frequently check their understanding to make sure that what you're saying is making sense. Okay, so And now OSCEs are UKMLA aligned. I know ours, they've changed it to like the CCA, clinical competency assessments. It may be a different thing in your university or whatever the case may be. So this is just to break down what that means. Stations are built from the MLA contents map, which you can find by just googling it, and the 3 themes they show in every station is readiness for safe practice. So are you able to prioritize? Can you escalate? Can you manage acute and common problems that you'll handle day to day in F1, or if you can't handle it, the main thing is here is, can you escalate the problem? Can you manage uncertainty? There'll be cases where some stations, especially in like our uni, they made the brief and the blurb and the actor, like what they give back to you, so vague, so it forced you to come up with differentials and not really know if you had the right differential. One case that comes to mind was a 10-minute station. It was an acute med station, and we had to take a history and then give an S-bar back to our senior reg, and the case seemed to be DKA or HHS. I think it was DKA. Most of us went with DKA. There was race ketones, and the like time course was a lot shorter than what you would see in like HHS. But still, it was uncertain. Like the actor exactly wasn't too sure, or like wasn't too clear. It also seemed like there may have been like a tropical disease nature as well, because he recently traveled and it was freshwater swimming and things like that. So they made it very vague, but the key thing here is they aren't trying to trick you. That you've definitely seen these conditions once or twice, be it in past med, be it on placements. So just stick to that, and if you don't know, follow the structure, answer everything to the best of your knowledge, and just do what you can. So yeah, these are the 3 themes here, and so the 4 layers that make OSCEs easy. Okay, so station 1 is the station algorithm. Okay, so these are some good things to know. It's the same every time. You will have 10 stations, maybe 5 for one day, 5 on the following day. I think my uni now is 5 on one day, 7 on the following day, 5 15 minutes, 7 10 minutes. There will be a communication station of some sort, be it breaking bad news if you're in final year, be it counseling or a patient on some drug medication, or breaking or counseling them on a drug mishap, for example. Maybe a patient had the wrong dose of a drug and it led to harm, or it didn't lead to harm, but you still have to have that duty of candor discussion with the patient. The clinical frameworks will be the same. So ATE assessments, our uni didn't really have ATEs. We just had like, it wasn't like the standard ATE exam. It was the ATE history, and then there's also Socrates as well, of course, which you all know for taking a good pain history, and then deliberate practice system. So you can practice and you can see yourself getting better each week, whether that's getting more fluent, not missing out on key questions of the history, stating good differentials, stating good management, etc., etc. Okay, so now let's go through the station algorithm, the 7 steps to win in every station. Okay, let's do it now. Okay, so the first thing is you have to be able to read the task, and then from there you have to be able to define your output. So what are they looking for you to do? Do they want a history, an exam, a counsel? Do they want you to interpret? Then when you enter the station safely, be it an exam or be it an history, mainly for exams, make sure to have good hand hygiene. So before you do your exam, say, I'm just going to wash my hands now, or just make it an effort to go and use hand sanitizer and like things like that. Introduce yourself, confirm your identity, consent. Then you can have opening line. So once you've given a quick summary of who you are, especially if you're in final year, just make sure to say that you're a doctor working here. I think for some reason every brief was like, you are a doctor working in so and so, and I still introduce myself as saying I am a final year medical student. So when you're in the OSCEs, you are a doctor. Treat yourself like that. Present yourself like that. Then data gather, which is just history taking. So take the acute history of what's going on, then ask the relevant questions just based on what type of history they're looking for. If it's a focused history, then ask questions that are specific to like that condition. I will help you to rule out the key things or the key red flags in that condition. So then summarize plus differential. So when you're going through your summary or your differential, it's also good to have like your thinking out loud, because of course if you stay quiet for too long. It may waste time. It may not look as good. Or if you are going to stay quiet, just say, okay, I'll just take 30 seconds now just to collect my thoughts and to formulate something. So just explain what you're doing. If you need time to think, that's fine. My friends did that, and they weren't marked down for it. Okay, it's, if anything, I feel like it'll make you more clear. It'll maybe reduce the likelihood of you saying ums and ahs, and hopefully will make them think, okay, this person is thinking clearly and they aren't rushing. Then plan for shared decisions. So you can then go through like your investigations, your management, or your safety net. So depending on what the brief wanted, if they wanted you to list key investigations or key management options, then you would list it now. If they wanted you to safety nets to the rights or to the relevant parties, then that would be a good time to do it. Then you close at the end of the day, you check your understanding questions, and then you can signpost the patients for next steps. Okay, so this is an example of what would be like your first 60 seconds would be. It's like, hey, hello, I'm a final year, I'm so and so, I'm a final year. Actually, no, you say, I am a doctor. If you're final year medical student, I'm sure that's your brief will say that you're a doctor. I am something, I am a doctor working in so and so, working in ED, working in GP. Can I confirm your name and your date of birth? And it's then boom, 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 boom. Then let them speak. Then give a brief intro into what the discussion will be about. So so today we will go through. We'll be explaining the medication that you've been started on, which is amisulprol. We'll just go through the key things that you should know about it, the key risks, the key things that you should be like aware of, and anything to watch out for in case there's any problems. It's okay to have a few questions. Boom. What were you hoping to sort out? So this is ICE, which you would normally do. I like to do it after you've gone through your history of your presented complaints. Then boom, after you move on to that, you go, okay, cool, that sounds really helpful. I'll do my best to help. So this is just like a sentence that like you could say after they've told you what the main problem is. After they've had the whole spiel for opening question. So if you're doing an exam, hand hygiene, chaperone offer, if that is relevant. You can also do a pain and comfort check. So to see, would they like to go and use the toilet right now? Let's say like you want to do an abdo exam. Are they breathless right now? Would they need maybe oxygen if it's like a respiratory exam, for example? Then just observe them by the bedside. How are they looking? What is the body habitus? Anything alarming? Is their skin red? Are they breathless? Are they coughing? Are they looking drowsy? Are they aware of where they are? Those are just some key things just that you can just pick up from looking at them. Then signpost to what comes next. Layer 2 is communication barriers. This is where the free marks live. So these are some things that you need to be doing. Communicate. So introduce yourself, explain your role clearly. If you're a final year medical student and you're doing your OSCEs, then they most likely ask you to say, I am a doctor. Again, just to clarify. So you are a doctor, you're working in ED, for example. Do you need to gain consent? If you're worried about breaking that's a professional barrier and escalating to someone senior, would you need to let them know, or shall you wait until after? Like, let's say like you're worried about DV and you're worried about DV happening to the kids that are at home, and the lady or the man there doesn't want to inform the seniors, but you're worried about the kids' health. Then you'd have to explain to them, okay, I'm probably, just because of this the concern to your children, I'll most likely have to escalate this to someone more senior. So is that something that may be needed here? Opening question first. What brings you in here? Why are you here? Actually, don't say why you're here. Just tell me why you're here. Then move on to focus questions. Then you can do ICE after your history of your presented complaints. I really like doing ICE. I try to work it in as much as I can because it can definitely tell you a lot. Especially after you've done your history of your presented complaints, you've asked your focus questions, you'll probably be around like the 3 or 4 minute mark. So it's good just to clarify what else they want or what else you need to get done within your 10 minutes or your 15 minutes. Empathy, so make sure that you're asking questions, you're looking, you're maintaining eye contact, you're leaning in if that's what's needed. Signpost them to relevant things. This may happen near the end. If you need to signpost them, like I say, it's like a DV station again, and you need to signpost like a lady, let's say, to women's aid or to her GP, or to inform her to go and keep like a bag somewhere in case. Use lay language or avoid jargon. Shared decision making. So as you're explaining down like the path, what you'd also have here is you'd also know what they want from ICE. So as you're explaining down the path here, you make a choice that also includes what the patient wants, whether that's in terms of the medication. If you can find some kind of compromise to, to give them a drug, let's say like they want an oral drug where you recommend IV or like an injection, can you find a middle ground? If not, can you explain to her why oral or IV may be needed more in like this case, despite their concern of like pain or fear of needles. It's just about working with the patient to find a compromise or explain why you're doing what you're doing. Safety net them, especially for like red flags. So if the patient has been started on antibiotics, if your symptoms are worsening after 5 days of or once you finish the course, if you have increased heart rate, increased respiration rates, new cough and new pain, delirious, drowsy, nausea, vomiting, they come back here, come to GP or go straight to A&E. They check understanding as well. So what do you understand? Just to make sure that I've explained this clearly to you, can you tell me what you understand from what I've said? That's a very good way to help you there. So difficult conversations, to keep it simple. So breaking bad news, spikes. So let me just have some coffee. So settings, plus privacy. If you're on a ward, can you go and move somewhere that is a lot less noisy, especially if you have, even if it's not breaking bad news, even if it's a discreet conversation that you feel the patients would probably better digest or feel a lot safer if they were somewhere safer. Maybe can you move her into like a family room or a private room to have this conversation? Perception, so what does the patient understand? And if they've come in here, if they've been sent for a 2-week wait because they had some blood in like their stool, what is the perception of what that test was even for, of what the 2-week wait pathway is, of why they're here today, of why they're seeing you today, of what the results of the test will even mean. Invitation. So how much detail do you need to go in when you're when you're explaining this back to them? Are they medical already? Maybe they already have an in-depth, maybe even better understanding of the pathology of the condition or whatever the case that they may have, or maybe they're a layman and they're in a different industry and they have no medical knowledge. So this may be a chance to be like, would you want me to explain this to this level of knowledge, or do you just want to know what this means for you going forward? Knowledge, so give them a warning shot. So so with this would be like, okay, so unfortunately I don't have the best news for you today. Unfortunately, sir, you were on a 2-week wait pathway as we found some blood inside of your stool. We've received those results, and unfortunately I do have some bad news for you. Then pause, give them time to reflect on what you're saying, let them break the silence. Okay, so what's going on? Then you'd be like, okay, so based off of your stool results, and you being here on a 2-week wait, and we sent you up for a colonoscopy, which is a camera test to look for signs of cancer, and from based off the biopsy, there is cancer present. Pause. Let them take in what you said, even if you were to keep speaking, because after you said the word cancer, they've most likely stopped listening to you, which is fair. So give them some pause and give them time to reflect on what else it is that they would want to say, or they'd want to discuss about, and then from there, strategy or summary. So you can now, after they've broken their silence, when they're ready to like reflect, you can then offer them things like, we can break the news to your family for you. We can, you will be discussed in an MDT meeting, explain what that is, with a team of cancer specialists that will decide on the best treatment outcome, or if treatment is even possible, or really just the best management outcome for you going forward. Maybe offer them, if they're a man of faith or the woman of faith, maybe they would like to have a priest or an imam come in, or things like that. So that's what this means. And when the actor is angry, they reflect and address the fact that they're angry. So sir, I see that you're angry today. I see that you're quite upset today. Is there anything that I can do to maybe help you to ease that feeling, or to validate, like, I understand that you're upset today, and 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 that is rightly so, because if I was in your shoes, I'd also be quite angry. I can't imagine what it must be like to be experiencing what you're experiencing. On my reset, I had a patient that came in, and when I walked in, he was pacing, he was alarmed, he was like, where's my grandmother? And it instantly had to be like, okay, cool, let's calm down, you set the pace. He was standing. Firstly, asked him to sit. If you like a seat, then you take a seat, and then just start to discuss from there. Okay. I've been talking for quite a bit now. Okay, let's keep going. Layer 3, core clinical frameworks. So these are just some things that you'd most likely, hopefully, should know for now. Probably will spend too much time on this. The generic time templates for taking a history, presenting complaints, the history of the presenting complaint. If it's a pain history, then use Socrates. Not sure what ROS is, but I assume this is a specific history or focus history, past medical history, drugs, allergies, family history, social history, ICE. Maybe not so much in this order. I'd like to have ICE roughly after the history of presenting complaints. So, okay, I think this just works better for me. Okay, and then we have ATE assessments. So look at things to look for, red flags, time course, again, severity, risk factors, meds, if they're on any form of anticoagulation, especially if they're in hospital. Are they on enoxaparin or are they on a DOAC? These are some things that if especially if you're on the ward, or if the brief says that you're on the ward, because it's something day to day, even working, that is often missed, which is is the patient on DVT prophylaxis? What is a baseline function? Escalation plan. So based on function, this patient that is here now, they're bed bound. Are we trying to get them to not be bed bound before discharge, or are they already bed bound? Like, is this how they were prior to them coming in? So if they're treated for whatever it is they're treated for, let's say a CAP, they can go home because this is their baseline already. So these are good things to know. Escalation plan. Especially in the case of a DNA CPR discussion, has this been discussed? Is this something that the patient would like to know more about? Is this station specifically about a DNA CPR, or is this something that you may have to bring up yourself because it's a patient that is like 89 or so, and it's very unlikely from the brief and history that they would be able or likely to survive CPR, and maybe they have a ward-based ceiling of care already, so it's something that you would look into, maybe to mention, even if you don't need to counsel fully on it. Psychosocial history, some things to look out for, mood and anxiety. So these are just some good questions. Sleep, appetite, the risk, substances, support, safeguarding, capacity, signposting. Examination station, so your universal script. So wash your hands, introduce yourself, gain consent, check if they have pain, especially if you're going to do something like an abdo exam. Do they have abdo pain beforehand? Would they like some paracetamol? Assuming there's no risk factors like you aren't worried about some liver problems. Expose appropriately. General inspection at the end of bed. Look at their vitals. Look at the bed next to them. Is there a drug chart? Is there any medications is there? Any other key signs? Is there an O2 tank? Is there a like bedpan or a vomit bowl? Maybe have a look inside. What's the contents of the vomit? You can definitely pick up a lot of things just from looking around. The focus exam: look, feel, move, plus or minus special tests, especially for MSK, for neuro. What I would say is just go through the exams the way that you were taught. So if it's look, feel, move, if that's how you've been taught your MSK exams, let's say, go through it in that order. Look from the bedside, look at each of the muscle parts. If it's a shoulder, look at the shoulder from the front, from the side, from the back, and then go from there. Oof, my light has just turned off. Just give me a second, guys. Okay. Let me just get this jumper on because it's getting a bit cold. So look from the bedside. And And then for special tests, if you do it at the end of the exam, then do it then. In cases like the neuro examination, I know like when you firstly, for like our uni especially, when we did the neuro exam and we did our gait assessments, we would then go to offer tests like Romberg's test or cerebellar rebound before we would then move on to like the upper limb examination, upper limb neuro examination. Then thank the patient plus cover, especially with tests like the DRE. Explain that you will expose them, you will do the test, and try and cover them after, just to protect their dignity. Then after that, you'll most likely be able to do a quick summary. So the quick summary, the way I would do it is, what is the key thing that brought the patient in, or I actually know who is the patient, why they're here. This is a 64-year-old man that came in with right knee pain. What are the key positives? So on examinations, there is erythema of his right knee, there is swelling, and there is crepitus. What are the key negatives? So on assessment of the function of his leg, he has unpreserved function. It's unlimited due to pain. There is no damage to his his LCLs or his anterior or like posterior like lateral ligaments, and this is known because he had a negative anterior and a posterior draw test. And in terms of red flags, he's not an IV drug user. Let's say he's not had any previous damage or any like injury to his right leg. If you're worried about like sepsis and like you're worried about like what was the mechanism that an organism could have been introduced into his right knee. So these are just some things that you can mention. Always add, then after any exam, I would do an examination then of the hip exam and the ankle exam and a lower limb neuro exam, just to conclude and to be thorough. Station 4 types. So for data interpretation, you may have a station. I think we had one that came up where it was a patient that came in with a query ACS, and they were giving us an ECG. So the first thing to do is, if there is something wrong with it, spot the abnormality, interpret it in context. So what does this abnormality mean? So let's say it's an ECG and you see ST segments elevation in leads 2, 3 and leads AVF. So you're thinking, okay, this is an inferior MI. Then you respond, what do you do next if it's an inferior MI on the background of STEMI? Is you go through your ACS protocol. I think most of you know by now MONA, so you could probably give them Oromorph, oxygen if their stats are less than 92, and nitrate, which would be like the GTN spray just to relieve the pain, and then aspirin. So what is the immediate loading dose of aspirin is 300 milligrams of aspirin. Then you then follow down like the protocol and see if if PCI is like possible, then you can give them like prasugrel, or if it's not possible, then you give them like fondaparinux or another like prasugrel and like clopidogrel, and like try wait to see if you could do PCI. I'm not too sure, but just go through the whole pathway for ACS treatment. But I'm pretty sure that was it. But let me know in the comments if that's not the case. And then always include urgency. So is this patient stable? Would they need to be escalated sooner or not? Is there any immediate actions that you can do, for example ATE if needed? And then at the end, again, summarize key differentials, key investigations, escalation, safety nets. Okay, then we have now a prescribing and a practical decision station. So the safe checklist. So what is the situation? So what are we treating? How urgent is what we are treating? I think we had a station that came up where we had to prescribe end of life anticipatory medications for a palliative care patient. So that was the situation. So we knew exactly what we were treating and what were the right meds that we'd need to have. So maybe some medication for like pain relief, some medications to help with secretions, some medications to help with anxiety. So then move on to is there any things that could impair or change the drugs you give? Allergies, adverse reactions, maybe look on the BNF for formulations for the route, any extra checks as well, any problems with like the renal function, their hepatic function. So these are things that you could find from the investigations, if there are any, or from like the nurses, if the nurses offer you any like tips, even in like the stations, maybe like the nurse may like leave a note for you, or from the past medical history. So then write it clearly. I'd like to use block capitals because I have rubbish writing, so I use block capitals, so it's very easy to read. Then I write the monitoring plan. Maybe try to do a duration. If it's antibiotics or 5 days, then put 5 days. Then review the patient after 5 days. So review things like their inflammatory markers. If it's a HAP, listen into the lungs. Maybe do a repeat chest X-ray if you need. Emergency stations. So again, emergency stations, we went through this a little bit. So ATE. So if you haven't done ATE, then go on Geeky Medics. They have very good ATE stations there, and they'll really be able to help you and to advise you guys further on how to deal with this. So with ATE, you have airway first, call for help. If they aren't breathing, or like you're hearing sounds and it sounds like there's airway obstruction, then it's better just to call for help, to like do the head tilt, chin lift thing, similar that their C-spine. Then you'd also want to like clear anything inside of like their throat. If there's any like mucus or like a gunk inside of their throat, that would be a good shot to clear. Check how their breathing is. So oxygen, respirates, auscultate, do tap and percuss their chest, look at their SATs and things like that. Circulation, pulse, cap refill, look at their blood pressure, fluid status at this point in time. Do they need IV access? Do you need to get fluids? Then you can move on to disabilities, so GCS, glucose, and exposure. So keywords I'm concerned about. I'd like my senior help now. I'll reassess after intervention. And could you also get the crash team, especially if you're worried that it's something severe? Then even if at any point in time you're feeling that this is out of your depth, then say that you would escalate to like your senior and reg, or if it's worse than that, that you just you put out a crash call and just get someone there immediately to help you. Handover. You may also have a handover station as well. So for us, some key things to have. Classic thing. The situation, who you are. I'm Charles. I'm one of the F1s working on this ward for endocrinology, and we have a patient here who is coughing up blood, or you'd actually use the right word, who has ongoing hematemesis, roughly 200 ml of blood, and their SATs are dropping and their blood pressure is 90/60. So just some key things to know and what's happening. So the background, this is a patient that came in 3 days ago with an upper GI bleed, and they were stable. They're not on any blood thinners, and right now they're worsening. Assessments, so unlike assessments I've seen, again 250 ml of bright red blood. Their SATs have dropped from 98 to 94, and the OBS are 90 over 60. I've pushed 2 liters of fluid, and I've also put out a crash call, and I've informed the blood bank because we'd like to like transfuse. I've done a group and save. Is there anything that you'd like to do right now? The recommendation, again, after you've said what you want to do, what do you want them to do? So would you like them to review the patient? Would you like them to come urgently and to prioritize this patient, or would you just like advice if what you've done makes sense and if they're happy with your plan so far? So you could do that. So practice system works. So deliberate practice. So how can you now go and practice this? Deliberate practice. So pick what you want to do, pick a time, have a good group of friends, maybe even have multiple OSCE groups that you could work in. Near to the turn from OSCEs, I was doing OSCEs with my friend group, I was doing OSCEs with my uni group, I was doing OSCEs online, and it really just made sense. I said pick one station type for the week. I don't know about this. I would just say try and do at least one OSCE circuit a week with at least one group of friends. Then you can do focused practice over teams, going through 1, 2, 3 stations of anything that you find difficult or they find difficult. Then near to the exam, once you've gone through everything, you can now just start doing practice exams, random stations of things that are high yield, that are likely to come up based off of the brief that they've given you in university, or maybe from discussion with seniors and seeing what came up in previous years, for example. Another key thing here is to use ChatGPT. I highly recommend ChatGPT. It really helped me to create stations that are a lot more challenging and difficult, and also more suited to my university stations, because you can definitely ask and tailor the stations to be suited to how your uni does stations. I found Quez Med also more challenging than Geeky. Not to say that Geeky is bad in any means possible, but Geeky, I think in fourth year was good. In final year, I thought there was a big jump, and I needed the OSCE stations that I was practicing to reflect that jump. Again, so do 3 timed reps. Definitely try and do them timed. Every station I'll say to do it's timed. Have key feedback from the station. Maybe even film yourself if you have time, and if you're worried and if you need some more stations, do use ChatGPT voice function, and also record yourself as well, and just take note of any mannerisms. This is why I also advise working with people that you are very close with or not so close with, because other people are more likely to pick up on negative mannerisms that you may not be able to pick up on. So identify 2 fixes, for example, 2 things that you do wrong or you want to improve upon, or maybe like you aren't finishing on time, or you're spending too long on your history and it's not focused enough. Do you need to maybe review the key questions for your OBS history, so you can ask more focused questions and not be asking things like travel when the patient has come in with like PV bleeding. Just some things that you can work on yourself, and you'll notice as you keep practicing. Then repeat on a new case. So on a random case that has started, it's good to go on repeat and to see what the case is there. Feedback that moves your score. So then when you're getting feedback, ask for feedback, things that feel unsafe. So key red flags that you've missed, if there's any free marks or easy questions that you've missed, things that you've phrased or that could need improving. So I think it's really good to do it with friends, especially friends that you know that are good at OSCEs, because even some things that the way they introduce themselves, or how they state things, or how they break bad news, it's just really good to like pick up on, and these are only things that you'll learn from new practicing. Any timing bottlenecks, again, maybe like you're doing a focus history but you spend too much time asking questions that are not relevant. If they wanted a comprehensive history, then they'll probably ask for that. Top 3 priorities for next rep. Oh, that's a good one as well. So what are your top 3 things that you think I can improve? So key top 3 takeaways, as well as all the other list of things that you need to improve. What are some top 3 key things that you can take away and move on to the next station? Avoid this feedback. So you were good, just be more confident, do more practice. Okay. Then make it your OSCE story. So drop your results in here, instant personal availability. Okay. Sorry, I don't even know how this made. So your OSCE debrief. So what were your top stations, your lowest station, most common stations? Oh, so these are just some notes that you can take. So you can even make this yourself. I used to make a lot of notes on my Apple Notes app for like different OSCEs, key things I missed, just because it's very easy, it's quick to write down. I did have a book, but sometimes I'd forget to bring in the book, and if the book isn't there, or if it's not as easily accessible, then it's not really any point. So just use Apple Notes. It's easy. You most likely always have your phone, so it's very easy to keep track of. So to keep to know your strengths, and to most importantly know your weaknesses, which can inform how you practice going forward. Okay, then your most common feedback themes, timing issues that you need to work on, and then confidence triggers. So what throws you off? Maybe it's a new patient, maybe it's a specific scenario or something that you haven't prepped for. Maybe it's like a breaking bad news or a depression station that you aren't really too good with. Then just ignore your 4-week plan. These are just something that I thought would be good. So again, fixed your first 60 seconds per session. And again, so work on the media things. Is your intro good? Can you say your intro and I would say less than 30 seconds, which I think is like reasonable. Oftentimes maybe one line may be sufficient for your intro, which could be 10 to 15 seconds. Is your examinations good? Is your structure good? Do you know it back to front? Can you go through it smoothly without calling out what you're doing out loud? That's interpretation. Maybe this will probably help by just doing more questions like on past med, or doing more questions on things like geeky medics, because they have a lot of different results and investigations to look through, even things like past tests. Then do full circuits or worse stations, or even like a circuit where you go through the stations that you find bad. That sounds interesting, very interesting. But full circuits, I think full circuits either online or in person are very good. Then 10-minute script practice up to the summaries. Exam day strategy, how to stay calm and focus on exam day. So reading time, so use your 1 minute wisely, or if you have extra time, use that wisely. So what is the station type? Know that straight off. Is it examination station, history, counseling, interpretation? What are you marking? What are the hotspots? What is the what are they asking you to do? Take a focus history from this patient. Then at the end, the light just fell down. Take a focus history from this patient. Then at the end, I want you to summarize to the examiner and then list your top 3 differentials or your top 3 tips from like management. So know what it is that you need to do. So in that station, know that you need to tick off all of those 3 domains if you want to have full marks. Now, what is my closing line? So thank you for coming in today. I'll now go on feedback with my examiner, and we'll let you know if there's any problems. Do you need a safety net as well, which is most likely very common and easy to do? Is there a follow-up that you need to do, or can you hand them like a flyer if you've give them some counseling, or maybe like if you want to like, direct them to a website as well to get some more information. Some good websites would be the NICE website or patients.info, but just on the patient section, or the BMJ but also on like the patient section, because I think like they explain it a lot better for like patients. And then if you blank the reset protocol, so if you walk into a station and you go blank, reset. So respiration, 1 slow breath, empathy, reflect what they said. Okay, so it maybe even ask your actor to repeat what they said. Anything like those things are fine, because it just gives you another second just to catch your breath, to recalibrate and to get back into the station. Summarize what had happened so far. So when you've taken like a history especially and you're not sure what's going on, you're completely blank, even if it's a condition that you know, for whatever reason you've just gone blank on what to do next. Summarize what has been said so far, explore their next key areas, and then also transition to a plan as well, which can also be helpful. So backup phrase. So let me summarize to check I've understood. There are a few important safety questions that I ask everyone. Again, so this is really good, because it looks like you're being thorough. It looks like you're actually trying to make sure that to the patient that you've understood, which is what you should be doing. You need to make sure to the patient that you've understood what they're saying and that you have a plan and you have a good understanding. So that is the end of the station, guys. I hope that this hopefully makes sense. This was sort of compiled off of like my ChatGPT and all the notes I've made while I've been helping a lot of students with like their OSCEs, and also when I was prepping for 4th year and final year for my OSCEs. So I really like how this PowerPoint's turned out. If you want me to send it to you, then please leave it in the comments below, and I can just email it to any of you guys as well. So I really hope that this makes sense. Good luck with OSCEs. Let me know what further videos or PowerPoints that you'd like me to do as well, and I'll see you guys in the next video. Goodbye.